Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover the Pro series of the diabetes therapy. In this Pro series video, we're going to follow through certain recommendations made by current guidelines in regards to diabetes treatment. The first one, metformin is your preferred initial pharmacologic agent for type 2 diabetes mellitus. There are certain considerations in regards to this one. The first one, it is not going to replace educating your patients and achieving lifestyle changes and cardiovascular risk factor avoidance. Now, metformin is only going to lower your glycated hemoglobin levels by 1 to 1.5%, so keep this in mind for the patients. Metformin also has certain contraindicated patients, and these are patients that have chronic kidney disease, decompensated heart failure, and lactic acidosis-prone patients. Also remember that metformin causes gastrointestinal upset, but for these you have an extended release formulation that you can add to these patients in order to avoid this side effect. Also, metformin is associated with a drop of vitamin B12 levels, so you should periodically check for these levels in chronic metformin users. Moving on to the second one, you have to consider combination therapy at treatment initiation for certain patients. Remember that some patients may present with glycated hemoglobins as high as 9 or 10%, and metformin is only going to help you through the first drop of 1 to 1.5% of such glycated hemoglobin levels, and any other added medication is going to help furtherly with 0.7 to 1% drop of such levels. This recommendation is made in order for you to avoid delaying treatment for such patients. So the second recommendation was made for oral agents added to metformin. But there's always the question of early introduction of insulin and what patients need insulin at the beginning. And so that would be patients that have either glucose toxic manifestations such as symptoms, ongoing catabolism with weight loss, or patients that already have an glycated hemoglobin level higher than 10%, or patients that are having glucose levels higher than 300 milligrams per deciliter. Now with these patients, after you achieve the reduction of the toxicity of glucose, you can wane insulin and achieve control with only oral agents. But if it is not possible, then you should continue with insulin injections. Now for number 4, you have to follow a patient-centered approach to guide the choice of pharmacologic agents. This is very important because there are so many things that you have to consider in regards to adding comorbidities and side effects for the patients, avoiding the development of hypoglycemic episodes or edema, or any patient that has other preferences in regards to weight, which is very important. There are some medications that promote weight gain, there are others that are weight neutral, and there are some that are promoting the patient to lose weight. And also, if the patient has or does not have the capability of paying for these medications. Moving on to the fifth one, we have that any patient that has type 2 diabetes mellitus plus an established atherosclerotic cardiovascular disease or increased risk for it, or established kidney disease or established heart failure, then these patients benefit from the addition of GLP-1 analogs or sodium glucose cotransporter 2 inhibitors, and these ones add to the cardiovascular benefit of the patient, and you don't even have to bother looking at their glycated hemoglobin levels. The management today is changing towards the cardiovascular outcome in these patients and not strictly on a certain glycated hemoglobin level. Now with the number 6, we have patients that have type 2 diabetes mellitus but do not have the previous mentioned comorbidities or risk factors. So what is the second medication that you should add for these patients. And that's going to be in regards to the point number 4, which was that you have to follow a patient-centered approach. But there are certain considerations. First, if you want to avoid hypoglycemia, then you should not add sulfonylureas. If you want to avoid edema, then avoid thiazolidinediones. If you want to promote weight loss, then you should add GLP-1 agonists or sodium glucose cotransporter 2 inhibitors. And in regards to costs, then you should ask the question if the patient is capable of paying for the medications, and if not, the most cheap medications for diabetes are going to be metformin, thiazolidinediones, and sulfonylureas. And now with the last recommendation, we have this question: what if we are no longer able to lower glucose levels with only oral agents? So many people think it is insulin the answer, but the current recommendation stands for GLP-1 analogs, and after those, then you should add insulin. And now that's going to be for the current recommendations on diabetic patients. Remember that this is a patient-centered approach and that you should always follow what you and your patient are comfortable with.